Yeah, thank you very much. And again, I'm very happy to be here and to discuss a somewhat provocative topic. I understand that part. But, you know, I can't stop of saying, Burkhard, fantastic images. And without these imaging, where would we be with mitral valve disease if we didn't have those? So those are my financial disclosures. And this presentation is meant to be provocative, idea stimulating, controversial, but hopefully also somewhat entertaining. It's somewhat that I'm hanging in the Shark Tank depending on where I give this presentation. I hope that here it is a little bit more smooth than in the United States, but nevertheless it is a provocative talk. We know that percutaneous treatment of mitral valve disease is messy and complicated. We all know this for the last actually 11, 12 years. There's a 20-year-old debate of how best treating mitral regurgitation. I think we agree on general treatment goals, reducing MR to minimal, treat early to allow the heart to remodel, at least to slow down dilatation, and keep future treatment options open, particularly for younger patients. Then we should select the optimal mode of treatment. For degenerative MR, still the best option is surgery. Functional MR makes sense, repair first, but select devices that keep future options open. We should always keep that in mind as we progress here. To date, there's no one mitral replacement approved in the US FDA and one approved in Europe. There are over 46 replacement projects in various stages of studies and developments. The management of mitral regurgitation has significant and shows significant differences in treatment paradigms between the two etiologies, primary and secondary. We see primary, the annual incidence 30% versus 70%. The penetration of surgery in primary is very high and secondary is low, and the guidelines are different. Class 1 in primary and Class 2A in secondary only in combination with bypass surgery. And here you can see the edge-to-edge modification or indication. Class 1 only in inoperable patients, and in secondary MR only high-risk patients. What are the lessons? And we should always keep that in mind, that surgery still is a standard of care. Lessons learned from surgery in the treatment of mitral regurgitation. Very simple, but very important. Mitral valve repair is superior to mitral valve replacement. Second, surgical techniques for mitral valve repair, the fundamental principles of mitral valve repair. Number one, restore or preserve full leaflet mobility. Second, provide a large surface of leaflet coaptation. And third, remodel and stabilize the mitral annulus. Also, in primary MR, we have good predictors for good long-term results. Number one, no residual MR. Number two, posterior leaflet disease is better than bileaflet disease, which is also better than anterior mitral leaflet disease. And second, ring annuloplasty. What are the emerging lessons from transcatheter edge-to-edge repair in the treatment of MR? Clearly, TEER has transformed the treatment of mitral regurgitation over the past decade from primary, both in primary and secondary MR, as published in the New England Journal of Medicine. Also, with additional evidence, experience, and indications, clinical use of TEER has steadily grown. Guidelines have evolved to support appropriate use of TEER for PMR or primary MR and secondary MR. So the question is, are we there yet? However, the more we study edge-to-edge repair, the more we understand its limitations and the challenges of treating mitral regurgitation. This is a summary, green, yellow, and red, as far as indication for TEER is concerned, and the treatment modifications. That's been agreed on at the Heart Valve Consortium, and it's well known to all of you. Many patients do have anatomies deemed prohibitively complex for TEER. Among those, anatomies associated with stenosis with TEER, anatomies associated with inadequate MR reduction with TEER, and other anatomic limitations that may preclude from performing TEER. Residual, unfortunately, residual MR is common in the real world. As shown on this slide, in the blue, you can see not all patients are leaving as wished with MR less than minimal or less than +1. Also, the impact of mitral valve complexity on residual MR is shown on this slide. If we go to straightforward TR anatomy, still more than 2+ in 9 to 16% of the cases. And if we move left over yellow to red, the more than 2+ residual MR is from 25 to 44%. Remarkable, and that's really not what we would like to see. Also, if you look at the treatment efficacy and stability, MR reduction at 2 years, looking at the treatment efficacy on the left side and treatment stability on the right side, in blue surgery, and in white TR, clearly surgery is better, both in terms of treatment efficacy and treatment stability. So despite the TR advances, the heterogeneity of anatomy and pathology suggests a need for additional non-TR approaches, such as transcatheter direct annuloplasty, the Silara, the Amand, and the Cardioband. Indirect transcatheter annuloplasty, most important, the Carillon device and the Arto device. And caudal replacement, even though what you can see here, harpoon is put to rest, and neocord is hanging on the string financially. So we're not doing so well with caudal replacement percutaneously, even though it is a very, very interesting approach and tries to mimic the successful surgical approaches. So the key questions remain. Number one, have we achieved the goal of eliminating MR with present transcatheter approaches, or do we have to find other out-of-the-box solutions? Number two, is reduction of MR alone sufficient to achieve our clinical goals? So if you look at this slide, and this is really a very important slide, 5-year clinical outcomes of secondary MR patients treated with TR suggest more is needed. If you look at the lower curve, 73.6% of the patients that received TR, so the device group, died or were hospitalized for heart failure. Clearly better than guideline-directed medical therapy, but still 74% of the patients are dead or rehospitalized. These findings emphasize the need for further therapies to address remaining MR and underlying left ventricular dysfunction in this high-risk population, the statement of the COAPT investigators. TR, unfortunately, at least so far, does not demonstrate evidence of reverse remodeling, despite MR, quality of life and functional capacity benefits, as shown here. However, therapies associated with reverse remodeling of the left ventricle are associated with improved clinical outcomes. What are the emerging lessons from EXPAND G4 study, a real-world study of the 4th generation TR devices? Clearly, as shown here, mitral regurgitation severity assessed by echo-colad has improved, left to right, more green than red or orange. That's what we would like to see. Also, progression of 1 year outcomes with a mitral TR therapy, both reduction of mitral regurgitation, we've done better on the left side over the years with the different studies, and reduction of mortality also decreased on the right side, looking at various studies. But if we look at the different patient populations, very important, COAPT patient population on the left side, EXPAND G4 population on the right side, hard to compare. If you look, the COAPT patient or the EXPAND G4 patients, smaller ventricles, better ejection fraction. And look, 40% of the EXPAND G4 patients had mitral regurgitation severity 1+ or 2+, questioning indication for TR here. Also, EXPAND G4 in secondary MR cohort, no left ventricular remodeling, looking at end systolic volume and diastolic volume. So the question, Michael Mack has asked that question many years ago, Is COAP a rising tide that floats all boats, or will it float only one boat? More accurate probably today than it was then. There are technologies that treat the dilated left ventricle with other innovations to complement TMVR approaches. Cardia MP, the BioCardia approach, the Lone Star Heart, and the ActuSync ventricular restoration system, as shown here. That particular system decreases wall stress, reduces left ventricular tenting, and decreases mitral regurgitation. And on the right side, you can see the left ventricle remodels, what we would like to see. Early clinical results of the ActuSync system demonstrate progressive reverse remodeling, shown on this side, ejection fraction and left ventricular and diastolic volumes. So what are the emerging lessons from transcatheter replacement in the treatment of MR? We know the goals and the challenges: ease of implantation, agnostic to etiology, reliable elimination of MR, and less recurrence of mitral regurgitation. However, we know the challenges: fixation, delivery, sealing, and the function, particularly left ventricular outflow obstruction. Still today, we have a high screen failure rate, as shown in the CHOICE trial, but everyone that tries to include mitral patients in today's percutaneous mitral replacement group has a screen failure rate between 60 and 80%, depending on the valve that you're choosing, mainly because of small ventricle, LVOT obstruction, annular size, and MEC. However, the good thing is, once we implant those devices as expected, we really successfully eliminate mitral regurgitation once and forever. Reality is, on the other hand, as 49 known replacement companies and projects, approximately $4.2 billion spent over the last 20 years on mitral replacement devices, and current outcomes do not show superiority over surgery. In part, they are marginally equivalent. So I think the question is aloud: are we on the right track looking at these expenses? There are clear opportunity, at least in my mind, for additional innovations. So what are those innovation solutions? And this is one thing very important when you look into new innovations, and particularly in the mitral valve space, but basically in all transcatheter spaces. The basic premise of transcatheter innovation is very, very clear. You cannot discover new oceans unless you have the courage to lose sight of the shores, which is to say, if we always stick to surgery, we've done this in TAVR, and we have been successful in TAVR. If we look at tricuspid and mitral valve, we're following the surgeons, but we're trailing the surgeons. So we have to look a little bit outside the surgical toolbox. Technologies that treat MR with hemivalves or leaflet augmentation may be the next out-of-the-box solution, transseptal approach intended to enhance or replace the posterior leaflet. One of those approaches is the Polaris implantation. Here's the very first case in Germany. You can see the screws. It's a posterior leaflet that adapts with the anterior leaflet. The half-moon coaptation augmentation device is designed to eliminate regurgitation by restoring physiologic coaptation in a diseased mitral valve. Shown here beautifully on the right side, the baffle is designed to swing anteriorly during systole. The clip and the brim work in tandem to provide fixation. A very interesting approach, and the first 15 patients of the second generation of this device will be presented next week at New York Valve. The first ever patient with this approach has been presented at TCT 2021 by Dr. Saar, and you can see here the device works very nicely, eliminating mitral valve regurgitation, and it keeps future options open. So, coming to the end, the emerging treatment paradigms in the management of mitral regurgitation. In the upper part, you see standard of care, and in the lower part, the patient population. Clearly, open heart surgery for low primary MR, I think that is very clear. And transcatheter edge-to-edge TEER from the left side to the right side Green and yellow, with the restrictions that I tried to explain to you, clearly an indication for TEER. What's left for percutaneous replacement is the right side, prohibitively complex TEER anatomy and very high surgical risk. We do know the early adoption of TEER is very clear, very successful. Frequency of residual MR, however, is concerning, and in pivotal trials of the replacement has potential, but at least today it is not broadly applicable. I would still like to make a case for the development of catheter-based therapies for the reasons that are summarized here. Less invasive, may be performed with fewer perioperative complications, and progression towards minimally invasive intervention impact clinical outcomes, quality of life, and healthcare cost. And finally, on the mitral side, now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. With that, I would like to thank you very much again, and thanks for having me.